Dear colleagues, left atrial appendage occlusion is considered as an alternative treatment option for patients with atrial fibrillation who have contraindications to oral anticoagulants. In relatively small randomized controlled trials, left atrial appendage occlusion was non-inferior compared to warfarin and more recently to direct oral anticoagulants for prevention of composite cardiovascular outcomes in patients with atrial fibrillation. Because survivors of intracerebral haemorrhage with atrial fibrillation were excluded from these trials, there is only limited evidence from observational studies regarding the role of left atrial appendage occlusion for this high-risk population. The safety of left atrial appendage occlusion followed by adjuvant antithrombotic therapy after intracerebral hemorrhage is not known, especially for patients at particularly high risk of bleeding. Despite these limitations, left atrial appendage occlusion has become an option in clinical practice for stroke prevention, and some stroke physicians even refer patients to interventional cardiologists rather than consider enrolling ICH survivors with atrial fibrillation into randomized trials of stroke prevention. Today, we have the opportunity to discuss with Professor Gregory Lip his view on the stains of left atrial appendage occlusion for stroke prevention in intracerebral hemorrhage patients with atrial fibrillation. So, Professor Lip, good evening.
Good evening. Thank you, Eleni, for the very kind introduction.
And I would like to start with my first question. Could you please give us an overview of data supporting stroke prevention in patients with atrial fibrillation by left atrial appendage occlusion?
Thanks indeed. Well, I suppose conceptually, that's the view that if you want to prevent strokes, you go for where the bit of the atrium in atrial fibrillation where the clot tends to occur most, and that's the left atrial appendage. And there are many pathophysiological reasons why that would be the case, because it's in terms of the rather narrow neck of the left atrial appendage, there's evidence of stasis there. There's obviously the prothrombotic state of the blood in atrial fibrillation, and then there's also some evidence of structural abnormalities within the endocardium and the wall of the atrium in patient atrial fibrillation. So you fulfill a lot of Virchow's trials. So clots, they tend to happen in the left atrial appendage, but I should point out not all the clots occur there. So in fact, if you look at the evidence, one of the strongest predictors of stroke, ischemic stroke in patients with atrial fibrillation is complex aortic plaque on the descending aorta. So whilst the atrial appendage is a source of clot, then it's not all the clots. So the concept of atrial appendage occlusion is that if the clots mostly happen in the left atrial appendage, if you block off the left atrial appendage, you hopefully would reduce most of the clots. And this was introduced as a interventional procedure on the presumption that warfarin was a very bad drug for you, causing all kinds of problems, difficult to monitor, and obviously the risk of major bleeding as well as intracranial bleeding. But of course, we're now in the era of the NOACs, non-vitamin K antagonist oral anticoagulants, sometimes referred to as the DOACs, direct oral anticoagulants. And of course, these drugs have many advantages over warfarin without the necessity for regular monitoring, and then furthermore, improved efficacy and effectiveness as well as safety when compared to warfarin.
Professor Lip, what about the trials on left atrial appendage occlusion? What are the strengths and the limitations of the available trials?
Well, the initial trials, well, if you go back in a bit of a history, there was the concept of left atrial appendage, percutaneous left atrial appendage occlusion is what I'm talking about. There have been other devices like the Plato device, which is now discontinued. and then subsequently randomized trials with devices such as the Watchman or Amplatz, where and the comparator largely was against warfarin. Now, contrast that to the anticoagulation trials, which use thousands and thousands of patients. These other trials with intervention with left atrial appendage occlusion with Watchman versus warfarin are substantially smaller. And the composite outcome, the traditional outcome of stroke prevention trials, all of us recognize with the traditional anticoagulation trials, the primary outcome is stroke systemic embolism. That's the primary efficacy outcome. The primary safety outcome for most of the trials is usually major bleeding. When you come to the left atrial appendage occlusion trials, the primary outcome is much more of a composite outcome with stroke, systemic embolism, as well as mortality, etc., and device related complications as well. So we are talking about things, different orders of magnitude, so to speak, because if you look at PROTECT and PREVAIL, the primary outcome is stroke, systemic embolism, cardiovascular, and unexplained death as the primary composite outcome. And actually, if you look within those trials, comparing the Watchman left atrial appendage occlusion versus warfarin, the composite outcome may be described as non-inferior, but actually, if you look at the ischemic stroke outcome, actually it was tended to be higher in the intervention arm compared to warfarin. The major advantage, you could say, was the bleeding outcome, but this was against warfarin, and there hasn't been a large enough randomized trial in the specific groups of left atrial appendage occlusion of patients normally or eligible for left atrial appendage occlusion when it comes to the patients with absolute contraindications to long-term anticoagulation, and those are quite few and far between, because once you've addressed all the major reasons for contraindication to bleeding, actually, at least in my AF clinic, which does have some complicated patients, actually you can reintroduce a NOAC in many of these patients.
And what about PRAG 17 that compares left atrial appendage occlusion with direct oral anticoagulants?
Absolutely. So the PRAG, for our audience, PRAG 17 was in patients where left atrial appendage occlusion was compared to NOACs, and in terms of the long-term outcomes, again, the primary outcome was based on a very composite type outcome: stroke, systemic embolism, cardiovascular death, bleeding, or other complications. And if you actually, in this group of patients, if you did look at stroke or TIA, you could say there really was not any significant difference between the left atrial appendage closure and the NOAC. When you come to bleeding, there was a difference, but it's worth reminding ourselves that in terms of the post-procedure anti-thrombotic treatment, many centers after left atrial appendage occlusion, despite what some of the guidelines also say, that they keep those patients on long-term aspirin. And my challenge would be, if they can tolerate long-term aspirin, why can't they tolerate a NOAC when in a large prospective randomized trial, which is averose in patients who decline or ineligible for anticoagulation, apixaban was superior to aspirin, and there was no difference in major bleeding or intracranial bleeding between the two. That was a trial that had to be stopped early because of that reason.
So, looking specifically at patients with intracerebral haemorrhage and atrial fibrillation, what is the current evidence for stroke prevention using left atrial appendage occlusion?
Well, not a lot, really. But having said that, if you look at anticoagulation, well, at least in the NOAC trials, that group of patients with a previous intracranial hemorrhage, that was an exclusion criteria for the large randomized trials. there have been various observational studies in patients after an intracranial hemorrhage. Then once stabilized, they whether or not they were anticoagulated or not. And in fact, if those patients with AF and an intracranial hemorrhage, they're actually if they're non-anticoagulated, they're actually very high risk of a subsequent ischemic stroke, as well as other as well as mortality and other cardiovascular complications. And those are actually reduced by anticoagulation, whether with warfarin or a vitamin K antagonist. And the benefit seems to be even better in the NOAC. Now, that you could say is observational data. In terms of large prospective randomized trials, there are still some which are ongoing, where we should hopefully try and answer this definitively. Some of the smaller trials that have either been presented or published, they are suggestive that it probably is okay, but may not be definitive in terms of the outcomes with regard to efficacy, safety. Well, as I said, relatively small trials. We need to see much larger trials to answer the question properly.
And focusing on those patients, which are the limitations of the left atrial appendage occlusion in high-risk patients?
Well, the left atrial appendage occlusion data, as I mentioned, it whilst it occludes the left atrial appendage, it doesn't necessarily prevent all the sources of thrombus. It's still, and even if you go back to PROTECT and PREVAIL, ischemic stroke actually was higher in the intervention compared to the warfarin comparator. Those trials are substantially smaller than the other stroke prevention trials, but they do depend on the composite clinical outcome. So it's worth remembering that aspect. In terms of those trials like PROTECT, PREVAIL, etc., they were not in the extremely high risk category of patients like those patients who are surviving an intracranial hemorrhage. They are not exclusively in that group of patients, because if you look at the patient profile in those groups of patients, they tended to be more in the sort of moderate risk of stroke. And you could argue that more contemporary trials ongoing, and even PROUD 17, it was trying to attempt to look towards the patient group more at high risk of bleeding. Nonetheless, the specific numbers with intracranial hemorrhage per se are relatively small compared to the larger stroke prevention trials.
What about an anti-thrombotics post-left atrial appendage occlusion?
Well, as mentioned, if you follow the current protocols, there needs to be a period of anticoagulation before, and then afterwards a period of antiplatelet therapy. And current practice among many implanters is to keep patients on usually aspirin. And if they can't tolerate aspirin, why can't they tolerate a NOAC in a sense? Because at least you have evidence based from a large trial that if you focus on the outcome of interest, which is stroke systemic embolism, there's no doubt that the NOAC or an anticoagulant is superior to aspirin. And in a NOAC compared to aspirin, there's no difference in major bleeding or intracranial bleeding.
Yeah. In your opinion, should the stroke center recommend participation in a randomized controlled trial of anticoagulation versus no anticoagulation, or rather refer patients for left atrial appendage occlusion to a cardiologist?
Well, I think if there's equipoise, we do a trial. And I think it's not unreasonable given our discussion here, because I think the evidence as we have it, if you're looking specifically at stroke systemic embolism, I think you need stronger evidence from well-conducted large prospective randomized trials. And I think just the reflex reaction, just the fact that they've had a previous intracranial hemorrhage, immediately go on to a left atrial appendage occlusion. I don't think that's necessarily right. I've got many patients who've had an intracranial hemorrhage in the past, and they've been referred up because they are difficult. They are these complex decision patients, and they've done very well actually after being started on a NOAC. So, you know, I don't think it's definitive that these patients must have a left atrial appendage occlusion, because I think if selected carefully, risk factors for bleeding are addressed. They actually do quite well on an anticoagulant as well. But you could say that, well, you could say, well, Greg, where's your evidence? Well, you need a randomized trial to do that properly, because what you have is largely observational data.
Yeah. But do you think that those patients, the patients who should receive a left atrial appendage occlusion after a multidisciplinary team decision, are the vast majority or just a few of ICH survivors with atrial fibrillation?
Well, since my move to Liverpool in just over 3.5 years ago, and I run an AF clinic, I think I've probably sent low single figures to my left atrial appendage occluder colleagues, and we are one of the largest centers in the country for left atrial appendage occlusion. And but what I'm so pleased I have implanters who are very rational and sensible when it comes to patient selection. So just off the top of my head, some of the examples of patients I've sent, I mean, it's a patient extremely high CHA2DS2-VASc score with atrial fibrillation with hereditary hemorrhagic telangiectasia. So you have that selected patients where basically any sort of anti-thrombotic therapy, whether it's antiplatelet or whether it's any anticoagulant, they just don't do well at all.
Yeah. So Professor Lipp, in conclusion, what is your current recommendation for stroke prevention in intracerebral hemorrhage patients with atrial fibrillation?
Well, I think it is to sum up some of the points that I already flagged up. And I think this group of patients are a complex group of patients, and the decision is not, by a single person, by a single cardiologist or a single, stroke physician, just to make that decision. And I think it's important that these sort of patients are appropriately discussed in a multidisciplinary team. You will get that small subset of patients where it is deemed that the harm potentially outweighs the benefit from oral anticoagulation, taking into consideration the patient, the comorbidities, the brain scan results, and everything else. And okay, that's that group of patients where left atrial appendage occlusion may be an appropriate strategy, and that's why it's a class 2B in the atrial fibrillation guidelines. But for many patients, again, if after appropriate discussion and selection, for them, and you could argue that's probably the majority, actually may well do quite well on a NOAC. And in terms of providing evidence, then I don't think the current published trials are large enough and robust enough to be definitive. And yes, there are still some ongoing trials, in particular high-risk groups of AF patients, where they're randomizing those high bleeding risk patients to NOAC versus left atrial appendage occlusion, but we have yet to see all those results as yet. But for now, I think it's not inappropriate at all to in this post-ICH AF patients, and this will be for most of them after appropriate discussion, and they can be reconsidered for reinitiation of anticoagulation.
Or maybe randomize patients into the ongoing randomized controlled trials, and in order to have good evidence for the future.
Yes, and I don't think anyone would doubt that the appropriately done prospective clinical trials are the best and highest quality evidence, and if in doubt, randomize, as the trialists would say.
I would like to thank you. I really enjoyed this interview. Thank you very much, Professor Lip.
No, thank you very much.
Dear colleagues, after this fruitful discussion, I would like to conclude that compared to trials studying oral anticoagulants for stroke prevention in atrial fibrillation, randomized controlled trials studying left atrial appendage occlusion versus anticoagulation were very small. Available data for left atrial appendage occlusion in intracerebral haemorrhage patients with atrial fibrillation is only based on observational studies with a substantial risk of bias. And importantly, enrolling intracerebral hemorrhage survivors with atrial fibrillation into ongoing randomized controlled trials for stroke prevention using either oral anticoagulants or left atrial appendage occlusion as an intervention is currently the best option for these patients. Thank you very much for your attention.